Hello everyone. In this lecture, we are going to study about anemia of chronic inflammation. Now, from the name itself, we can understand that this is a type of anemia which happens in patients who are having a certain type of chronic inflammations. So it can be due to chronic infections like tuberculosis, like bacterial endocarditis, or it can be due to long-standing lung abscess. Certain immunological disorders can also cause this disease, like rheumatoid arthritis and inflammatory bowel disease, and various neoplasms like CA lung, CA breast, Hodgkin lymphoma, etc. So various neoplasms can also cause this disease. Now let us understand what is the pathogenesis. Basically, there are two important mechanisms that we need to remember. The first one is decrease in erythropoietin production from the kidney. And the second mechanism is increased interleukin 6. So what happens because of decreased erythropoietin? Now, erythropoietin stimulate the process of erythropoiesis. Especially, it acts on the colony-forming units inside the bone marrow. They act on the colony-forming units and stimulate them to proceed for the erythropoiesis. So this is the pro-erythroblast. So for this conversion of colony-forming unit erythroblast to pro-erythroblast is stimulated by erythropoietin, and subsequently it will cause further erythropoiesis. So the erythropoiesis, the process of RBC production is affected, and also there will be a state of functional iron deficiency because of increased interleukin 6. As we have discussed in the lecture of iron metabolism, that interleukin 6 can act on hepatocytes. It can cause increased production of hepcidin. So interleukin 6 can increase the production of hepcidin. Now this hepcidin can go and degrade the ferroportin molecule. It can degrade the ferroportin protein. So ferroportin is a channel protein that is required for basolateral iron absorption in the duodenal epithelial cells, and also it is required for release of iron from the macrophages. So this interleukin 6 will cause increased hepcidin production from the liver, and this hepcidin now it will go and it will inhibit the iron absorption in the duodenum, and also it will inhibit the iron release from the macrophages. So this will lead to a state of functional iron deficiency. That means the body stores are enough. Okay. So iron stores in the body is sufficient, but this cannot be utilized because it cannot be released from the stores because of this increase in hepcidin. So this is known as functional iron deficiency. So in anemia of chronic inflammation, we will have both a decreased erythropoiesis and also we will have a component of functional iron deficiency. Okay. Now, actually, this anemia of chronic disease is described as a consequence of protective mechanism. Why it is described like this? There are certain organisms, for example, Haemophilus influenza. So basically, there are certain organisms which are dependent on iron for their growth and survival. So they are dependent on iron. And by the process of increasing hepcidin, the body is not providing enough iron to these organisms for their growth. So that is one protective mechanism. And the second one is hepcidin is actually a family of defensins. So defensins are a group of proteins which have this antibacterial activity. They have antibacterial activity, and hepcidin belong to this defensin group of proteins, and it is thought that hepcidin also has some antibacterial activity. Okay, so increase in hepcidin during this chronic inflammatory process, especially during chronic infections, is actually thought to be protective. But as a consequence of this increased hepcidin, it is also leading to production of this anemia of chronic disease. Okay. Now, what happens in anemia of chronic disease? There is high iron inside the cell, as you have discussed already. Because of this increased hepcidin, the iron cannot be released from the stored sites. So inside the cell, inside the macrophages, we have enough iron, but that iron cannot be mobilized for the production of hemoglobin. Okay, so because the iron inside the cell is sufficient, now these iron regulatory proteins, they cannot bind to iron response elements. So this basic concept we have discussed previously also. Okay, whenever there is enough iron, iron regulatory proteins cannot bind to iron response elements. If they cannot bind to iron response element of ferritin mRNA, it can actually increase the translation of this mRNA, so there will increase in ferritin. Already these cells will have increased ferritin because this iron is not getting mobilized from these cells. So already they will have increased ferritin. Over that, it can also increase more and more ferritin production. So the ferritin will increase. Okay, so the serum ferritin will increase. Of course, the serum iron will be reduced because it is not getting mobilized from the reticuloendothelial system, and it is also not getting absorbed from the duodenum because of increased hepcidin. On the other hand, if the iron regulatory proteins cannot bind to iron response element of transferrin mRNA, there will be reduced translation of transferrin mRNA. So that will cause reduced transferrin. And this reduced transferrin is responsible for reduced total iron binding capacity also. So transferrin and total iron binding capacity will be reduced. So what will happen to soluble transferrin receptor to log ferritin ratio? So transferrin receptors, that is reduced, and ferritin is increased. So the total ratio will be reduced. So it is less than 1. It will be less than 1. And we have discussed in iron deficiency anemia, this ratio is more than 2. In iron deficiency anemia, this ratio is more than 2. So these are the point of difference between anemia of chronic disease and iron deficiency anemia. Why it is important? Because many times they behave similarly, and sometimes iron deficiency anemia can coexist. I mean, absolute iron deficiency can coexist with anemia of chronic disease also. And in this condition, at least in the initial stage, you are going to get this normocytic normochromic RBCs. But as more and more functional iron deficiency sets in, they are going to develop microcytic hypochromic RBCs. Okay, so they will start with normocytic and normochromic RBCs, and they will proceed to microcytic hypochromic RBCs. Okay, and treatment for this condition is to treat the underlying cause. Okay, so that's all about the anemia of chronic inflammation.